All right, so it's 6 o'clock. We're going to get started here. So welcome, everybody. Thank you for taking the time this evening. Just a couple of housekeeping tips and items before we get started. Please use the Q&A feature at the bottom of the Zoom screen. Actually says Q&A, and they look like two sort of chat bubbles to submit your questions throughout the talk. These will be addressed at the end, so there'll be time for Q&A at the end of Dr. Minkis's presentation portion. Also, the session will be recorded, and it's going to be made available online for later viewing too. So if for some reason you can't stay for the duration, it's not a problem. I'll be sharing the video link with you all shortly after the talk. So we're very excited to have Dr. Minkis with us tonight to talk about strategies for minimizing a risk of developing skin cancer. And you can see from the title here, Loving Your Skin. Dr. Minkis specializes in the treatment and prevention of skin cancer and is the director of Mohs and dermatologic surgery at Weill Cornell. She has extensive training in surgical removal of early stage melanoma and extensive research experience in the role that the immune system plays in skin cancer. From her personal statement, Dr. Minkis prides herself on being friendly, caring, attentive, and compassionate to her patients, striving to ensure they feel comfortable, have their needs met, and all their questions answered. So with that, Dr. Minkis, I'll turn it over to you.
Thank you very much, Antonio. Okay, so let's see. Okay, here we go. So this talk is broken up into two parts, essentially. The first part will review some of the most common rashes in dermatology, as well as how to care for your skin on a daily basis. And then part two will focus more on really what I do in my day-to-day practice, which is the treatment and care of patients with skin cancer, and giving guidance on how to protect your skin from the sun. So let's start with the different types of rashes. So first, let's just start about talking a little bit about how our skin changes as we age. So there's lots of different ways in which the skin changes on a microscopic level and then on a level that we can see. So there's decreased water content. There's decreased lipid content in the stratum corneum, which is the top layer of the skin. And for both of these reasons, the skin tends to get a little bit more dry, and increased number and size of the corneocytes, which causes a little bit more flaking of the skin. There's also a decrease in the size of the sebaceous or oil-producing glands in the skin, as well as the size of the sweat glands, and reduction of the vasculature or the blood vessels in the skin. You could see there's also usually a less thick layer of the subcutaneous fat layer of the skin, so the skin tends to become thinner in all of its different compartments as we age. The most common skin conditions that we as dermatologists treat are itching, eczema, seborrheic dermatitis, psoriasis, and shingles. So obviously what we do is quite broad, and we see hundreds of different types of skin conditions, but these are the 5 that I'm going to focus on just because they're the most common ones that we see presenting to us. So itching is a very, very common presentation, and it's one of the most common dermatologic complaints, especially in patients that are greater than 65 years of age. And although it's a very common dermatologic complaint, it's oftentimes unrecognized or underdiagnosed. So pruritus, which is itching, has been studied pretty extensively. And in one population study out of Norway, they showed that about 1/4 of patients reported having itch as a symptom in their life. And this was a pretty large study with almost 20,000 patients. And then there was another Danish study that revealed that it was only reported in 2.5% of patients, while other things such as unspecific eczema or other were much more commonly reported. So that's why we know that it is underdiagnosed and underreported. There are many, many medical reasons to be itchy. So generally speaking, we break up itching or pruritus into 2 separate categories. One which has an itch with a rash, and that's listed here in this column. And the other one is a generalized itch without a rash, And what you'll notice here is for the second column that most of the things listed here, and you don't have to necessarily focus on every single one of them, but many of them are actually due to internal diseases. And therefore, it's important for patients that have pruritus to present to their either dermatologist or primary care doctor, because sometimes it's important for us to work that up to look for the actual cause of it, because some of these causes are quite important for us to be able to diagnose. And sometimes the only presenting symptom could be itching. So that's not to scare anybody whose skin is itchy, because again, that's a very, very common complaint, and most of the time is not due to any of these. But if it is, it's important for us to be able to make that diagnosis. So some of these we'll focus on today, and that's generalized itch with a rash. We will not be focusing on the itch without a rash, because that is outside of the scope of our ability to discuss today. So the first thing that we'll talk about is eczema. So eczema is the same thing as dermatitis, which I'm sure all of you have heard the term dermatitis before. So if we break up that term dermatitis into derma and itis, derma means skin and itis means inflammation. So dermatitis essentially just means inflammation of the skin. Is a very non-specific term, and we oftentimes use it to describe many different types of skin conditions. So what constitutes eczema? Any itching rash, any red itching rash that has scale or is dry, any itch that rashes, and any rash that cannot otherwise be identified, oftentimes is just non-specifically called dermatitis. The prototypical eczema rash that we think about, which occurs mainly in children, is known as atopic dermatitis. And that is a very specific type of dermatitis, and it's usually associated with the triad of atopic dermatitis, eczema, which is eczema, as well as asthma and allergic rhinitis. So oftentimes we'll see kids that present with atopic dermatitis or eczema of the skin, and they'll also have a propensity to have asthma as well as seasonal allergies. But there are other different types of eczema. So here's an example of something called asteatotic eczema. And if you look at the presentation, you can see that there is cracking of the skin, and it almost resembles a dry riverbed. And that's actually how we describe it. So it's dry, it's rough, it's scaly, and it's inflamed skin with superficial cracking that resembles a dried riverbed. The most common site of predilection are the shins, the lower flanks, and the posterior axillary line. It's often associated with aging, dry skin, or xerosis, which is dryness of the skin, as well as relatively low humidity and frequent bathing. So we're more frequently seeing this in the winter months due to relatively low humidity. Another common presentation is stasis dermatitis. So stasis dermatitis results from increased pressure of the leg veins, along with leaky valves, which occur in the veins of the lower extremities, the deep leg veins, and that occurs over time. There are certain conditions that could lead to this more frequently, such as heavy weight gain, pregnancy, anything that puts pressure on the vasculature of the legs. But sometimes just normally over age, the valves in the lower legs become a little leaky, so they can't pump the blood back into the general circulation as well as they were able to before. And this causes fluid as well as red blood cells to leak out from the veins itself into the surrounding skin. And so you'll notice the legs often become more swollen. So as the day goes on and you're walking around, oftentimes the legs will become more swollen later on. Whereas when you are, early in the morning, because you've been lying flat, you don't notice that as much. And then once you start walking and gravity takes effect, the blood and fluid starts to leak out from the vasculature and lead to the veins become a little bit more leaky, and it leads to more swelling in the lower extremities. Over time, this causes an inflammatory reaction, and this becomes chronic, which means long-term. And oftentimes, because you also have some skin breakdown with this condition, You can also have allergic reactions in the area because you have an impaired skin barrier. So patients will start to self-remedy with various different topical medications, and this will lead to then development of an allergic reaction. So oftentimes the two of them could go hand in hand. So the treatment is twofold. One is to treat the underlying cause of this, which is reducing the venous hypertension. And we do that with things like compression stockings, which help to improve venous return or help repair the leaky veins by pumping the blood back into the general circulation. Leg elevation, which is essentially the same thing as you're doing at night, which is helping to counter the effect of gravity on the legs. Calf muscles, which also help to pump the blood back. And diet and medications, which sometimes are important, particularly in patients with heart disease who have some fluid retention and therefore can have more swelling of their legs and more likely to develop stasis dermatitis. And then the treatment for the symptoms is topical steroids and emollients, which are, you'll hear me use that term emollients over and over, and that just refers to skin moisturizers. Nummular eczema is another type of eczema, often also results from dryness of the skin. Nummular means coin-shaped, and as you can see at these photos, these are often coin-shaped areas of thick and dry skin that's scaly. And it could be seen in patients that also have asteatotic eczema because it's similar causes. It could be disseminated, but most likely you'll see it on the arms and the legs, and more likely in older men, probably because they're less likely to use a moisturizer. Sometimes it could present with weeping, but usually they're thickened and flaky and can present with intense itching. Contact dermatitis is basically an allergic reaction to the skin. So there's two types. There's irritant contact dermatitis from irritation of chemicals on the skin. We were seeing a lot of that during COVID because people were using a lot of hand sanitizer as well as various, Lysol and various types of cleaning agents. And so we saw a lot of irritant hand dermatitis. Here we're seeing allergic contact dermatitis, and that is essentially a rash that occurs when an external allergen comes in contact with the skin. So something that you're allergic to that comes in contact with the skin. The prototypical reactions are from poison ivy or from nickel. So those are two of the most common ones. We also very commonly see it with the over-the-counter antibiotic topical medications such as bacitracin, for example, or neosporin. So we're also oftentimes very wary of patients that are using that because 10% of the population can develop an allergic contact dermatitis to those chemicals. Sometimes we just see a localized patch that occurs at the site of contact. For example, where you see the buckle, which contains nickel, and this lady's necklace is causing this rash to appear. However, there is something called autosensitization, and that essentially means that it's spread to the entire body. So although you're not coming in contact with that same chemical or substance everywhere, your immune system is hyperactivated and you start to develop the rash even at remote sites where you're not coming in contact with it. And the way that we diagnose it is with a procedure known as patch testing, and it helps us to determine which allergen in particular you're allergic to. Dyshydrotic eczema is another type of eczema that occurs, and most often it occurs on the palms and soles. It presents as itchy blisters, very intense itching, and it can be associated with atopic dermatitis as well as contact dermatitis, both allergic and irritant. And despite the name, it really has no disturbance of sweat glands. So it's called dyshydrotic eczema, but there's no sweat gland disturbance. So the treatment of dry skin and eczema is essentially to bring the moisture back into the skin and avoid stripping the skin of its essential oils. And the way that we do that is by frequently using bland emollients, particularly after bathing. And bathing itself, you want to avoid hot, long showers. Take a mild, quick shower, about 5 minutes or less. You want to use unscented soaps, mild soaps, ones that are non-irritating. And you should use those to most of the areas. Sometimes, you know, to areas like the underarms, you could use a different type of soap that's a little bit stronger, but most of the time, a mild, gentle soap could be used everywhere. Avoid friction from washcloths. You really want to avoid extensively trying to scrub the skin because it could actually make it worse. And we often recommend, especially in New York City, in the winter time, where, you know, once the people are living in the apartments and once the heat comes on, the air becomes very dry, replacing some of that humidity by using a humidifier. And also treating the inflamed skin with the help of a board-certified dermatologist by using appropriate prescription strength topical steroids. Now you have to be careful because they can have side effects, but if done with the care of a dermatologist, it should be safe. So the other thing that's important to do is use skincare products that match your skin's needs. So figure out what skin type you have, whether it's oily or dry, normal, combination, or sensitive. And there are various products that are formulated for that specific skin. Resist the urge to scrub your skin because it could actually make certain skin conditions, including eczema, worse. So that scale that's on the surface, it's not going to go away by just scrubbing, and you could actually make the eczema worse. Wash your face in the morning and before bed, or if you sweat, to remove any grease or oils or makeup. And be very gentle when you wash your face. Just wash it with lukewarm water, a very mild cleanser, and pat dry gently. Oftentimes we get the question of what's better, cream or lotion. So generally speaking, if you have very dry skin, something that's greasier is better than something that is more water-based or liquidy. So a cream is better than a lotion from that standpoint. And then ointment, which is even greasier than a cream, and that's more of a Vaseline type consistency, is even better than a cream. However, it also depends on the condition and on the time of year. So oftentimes in the winter time, we'll recommend the greasier the better, so an ointment or cream. And in the summertime, when you tend to sweat more and there's more moisture in the air and your skin is less dry, a lotion can be preferred because you'll feel a little bit less hot from it. So which emollient to use? There are so many different ones on the market. So this slide just shows 4 of the most common ones that you could find at your local drugstore. They all have various different lines in them. And there's not one in particular that's better than the other. It really depends on your specific skin type and on your preference oftentimes. But there are some things that we recommend looking at the product label for. So one is for the word hypoallergenic. So if it says hypoallergenic, it's less likely to cause an allergic reaction. There's still a risk because not every chemical obviously is excluded, but the most common ones generally are excluded from the product. And non-comedogenic or non-acnegenic, which essentially means that it does not cause acne, which is pimples. It doesn't clog the pores, and therefore, especially if you're going to be using it on like the face, for example, I always recommend using a non-comedogenic product. Buying a product that's formulated for your skin type, as I mentioned, is important. And there is not really one size fits all. So it's a personal preference, and you could talk to your doctor to determine the product that works best for you, or you could try various ones until you find the one that you prefer. And the best product is the one that you're actually going to be able to use and be consistent with using. There are also medical therapies for eczema. They include anti-inflammatory topical steroids that help to reduce the number of immune cells, but they have risks associated with them. And so it's very important that this is done under the guidance of a dermatologist. Menthol products give a cooling sensation to the skin, and sometimes we recommend this for patients with pruritus. These are over-the-counter medications, and they could be used as frequently as you want. They're very safe, and they're more for symptom relief. Antihistamines we sometimes prescribe for itching, mainly because of their sedating effect. They have a very mild effect on itching, but they are sedating, so they help you sleep better. And sometimes people can focus on itching more at night, but you do have to be careful, especially in older patients. And phototherapy is a very safe and excellent choice for both younger and older individuals. It has an excellent safety profile. It's essentially like a UV lamp that's in a box, and it's prescribed by a dermatologist generally. The downside of that is, although it's very safe and you avoid the side effects of medication, you do have to come into the office usually 3 times a week to have this done. Another very common condition that we see is called seborrheic dermatitis. There's an infantile form, which we see in children or infants, and an adult form. It's essentially on the scalp, but oftentimes just looks like flaking of the skin or dandruff. But it affects more than just the scalp. It also affects areas like the ears, the face, in particular the central face between the brows and on the sides of the mouth. Like the smile lines, as well as the skin fold areas. And what causes it is an active sebaceous gland and abnormal sebum composition, as well as a reaction to a yeast that's very common on the surface of the skin called Malassezia furfur or Pittosporum ovale. And this yeast is very ubiquitous, so it lives on many people's skin, but sometimes people are more likely to react to it. There's also some severe forms of this condition that could be a sign of underlying medical conditions such as HIV or neurologic disease such as Parkinson's. The treatment of seborrheic dermatitis includes increasing hair washing, so you want to remove the excess oils from the hair, using an anti-dandruff shampoo, such as one that contains parathione zinc or selenium sulfide or an azole, which helps to decolonize the yeast. There's also other shampoos that are tar or sulfur based that they have anti-inflammatory effects, and topical steroids can be used if it's more involved, or sometimes we use a combination of anti-yeast and topical steroids in certain areas like the face. Psoriasis is also one of the most common presentations to the dermatologist. It's an autoimmune or immune-mediated skin disorder. It has various environmental triggers as well, and it could essentially the way that we describe this is a sharply demarcated erythematous plaque with a micaceous scale. So it's basically thickened red skin, which has a thick white scale on it. And it's very well circumscribed, meaning it looks very separate from the rest of the surrounding skin. It occurs in about 2% of the world's population, so very frequently, equally in males and females. And there's 2 main peaks of occurrence in the 20 to 30 age group, as well as in the 50 to 60 age group, but we see it in all ages, including young kids and including elderly patients as well. About 2/3 of patients have mild disease and 1/3 have more moderate to severe disease. And generally it's a lifelong disease. We do have lots of different treatment options, which I'll talk about on the next slide, but it oftentimes remits and relapses, and it could be unpredictable. So when somebody first presents with it, we can't really say with certainty exactly what course their disease will take. The symptoms include pruritus or itching, pain. Sometimes if it's very extensive and covers the whole body surface area, you could have heat loss problems, but most complaints are of just the appearance of it. So patients present with low self-esteem, they're embarrassed, they feel like outcasts, and they're also bothered by the excessive scale. It's also very important for us to know that psoriasis is associated with a constellation of symptoms known as the metabolic syndrome. And this includes hypertension, diabetes, and obesity. And severe psoriasis is associated with a 3-fold increased risk for heart attacks and a 3 to 4 year reduction in life expectancy. So this is very important, not just for dermatologists, but for primary care doctors to be aware of as well, and for patients to be aware of, so that they could follow closely with their general practitioners and make sure that they're getting screened for things like high blood pressure, diabetes, eating a healthy diet, and losing weight if necessary. 20 to 30% of patients with psoriasis could also develop arthritis of the fingers and toes, and that's called psoriatic arthritis. This could be very debilitating and irreversible. So if patients develop psoriatic arthritis, it's very important that they go on systemic medication that can help to treat their psoriasis as well as their psoriatic arthritis, and oftentimes this is done in conjunction with a rheumatologist. So the conventional therapies for psoriasis include, depending on the severity and extent of it, things like topical medications, including topical corticosteroids or topical vitamin 3 analogs or retinoids, as well as phototherapy, which can be very helpful, and systemic therapies, which include oral therapies or biologics. So right now, this is a very exciting time to be in dermatology and in dermatologic research. A lot of research has been done about the etiology or the cause of psoriasis, and we know the pathway that leads to the development of these skin lesions, and therefore a lot of new therapies, more than one could even keep up with, are either already approved or in the pipeline for the treatment of psoriasis and psoriatic arthritis. So there's really quite a lot of various treatment options, and it could be tailored to one's underlying medical problems, whether they have arthritis or not, the degree of involvement, etc. It's also important to have behavioral lifestyle modifications, including avoiding smoking, maintaining a healthy diet, and living stress-free, which I don't know if anybody's living stress-free now, but we could all aim for it. Now switching gears a little bit, I'm just going to talk very briefly about herpes zoster, also known as shingles, which is how most of you probably know this. So it is a painful rash that is caused by the varicella zoster virus, which is also the chickenpox virus. So essentially, once you have chickenpox, that virus stays in your system or in your body indefinitely, and it stays in the roots of the nerves. And so when it presents itself as shingles, it basically represents along the path of that nerve that it is reactivated in. And so that's why we usually see it only on one side of the body and in a cluster. And could develop at any age, but more common in either elderly patients or in those with impaired immune systems. It usually presents as itching, tingling, burning, and typically on one side of the body, and then it develops with blisters, and we describe it as dewdrops on a rose petal. And the blisters then crust over the course of 7 to 10 days, and the rash typically resolves in about 3 to 4 weeks. It is contagious for those that have not been exposed to chickenpox. So if somebody has not already had chickenpox, they could develop chickenpox by being exposed to somebody with shingles. So you can't give anybody shingles, but you can give them chickenpox. And if they have not had it, or if they no longer have immunity to it. So it's important, if you develop herpes zoster, to avoid pregnant females because their unborn fetuses can be exposed, young children, as well as those with compromised immune systems. The complications are post-hepatic neuralgia, which is persistent pain after the infection even clears, and usually lasts for more than 3 months. And this occurs in about 10 to 15% of patients overall, and more than 50% of those that are over 60 years of age. So for this reason, it's important that we diagnose and start treatment as soon as possible. Also, you could have other complications such as skin infections, bacterial infections due to the compromised skin barrier, eye inflammation. So if you have any blisters near the eye or near the ear, it's important that you tell your dermatologist or your primary care doctor, because that could be potentially serious if the herpes zoster affects either the eye or the ear. And the treatment includes antiviral medication. The earlier we start them, the shorter the course and the less likely to have post-herpetic neuralgia and other complications from it. And then the Shingrix vaccine, which is the preferred vaccine by the CDC, which is 91 to 90% effective at preventing shingles, but even more importantly, it's 89 to 91% effective at preventing long-term nerve pain. So even if somebody develops herpes zoster after receiving the vaccine, the likelihood of them developing post-herpetic neuralgia is significantly decreased. There's no maximum age, and it's given in 2 doses. So now shifting gears a little bit, I'm going to briefly talk about skin cancer and sun protection, and then hopefully leave some time for questions at the end. So types of skin cancers are multifold. Skin cancer is an abnormal growth of skin cells, most often develops in areas of sun exposure, and this is because it is well recognized that it is significantly due to the cumulative UV exposure on the skin that causes this abnormal growth of skin cells, which becomes skin cancer. It affects people of all colors and all races, but the ones that are most predisposed are those of lighter skin who sunburn easily. The incidence is, it's quite frequent. Basal cell carcinomas are the most common skin cancers, more than a million, quite more than a million, more in the 3 million range are diagnosed each year, followed by squamous cell carcinomas and melanomas. However, the mortality the ratio is shifted, with melanomas compromising about 3/4 of the mortality or so of skin cancers, and then the squamous cell and other being much less likely. The frequency of developing a non-melanoma skin cancers increases exponentially with age. So this graph here shows age groups clustered in 5 years. So it starts at 65 and then goes up to 85, and shows the frequency of total non-melanoma skin cancers, and also breaks it down based on the subtype, basal versus squamous cell carcinoma. As you can see, all of the different types of non-melanoma skin cancers increase with the decade of life. About 90% of non-melanoma skin cancers are associated with exposure to UV radiation from the sun. But it is also important to note that a healthy and functioning immune system is important for preventing development of skin cancer. So in patients that have compromised immune systems, such as those that have organ transplants, for example, where they're given medication to suppress their immune system so that they don't reject their organ, they are much more likely to develop skin cancers. And in fact, squamous cell carcinoma, which is the second most common type of skin cancer in patients with normal immune systems, is actually more common than other kinds, and increases at a frequency of about 100 times compared to the general population in organ transplant recipients. And it's important for all patients, whether or not you have an impaired immune system or not, to protect your skin from the sun by using appropriate sunscreen and other sun protective measures to prevent the development of skin cancers. So what does skin cancer look like? Well, all of these are examples of basal cell carcinomas. Basal cells come in various different forms, and on the face, the most common is called nodular basal cell carcinoma. Those present as pink pearly papules. We call them pearly because they have a pearl-like shine to it. And oftentimes they could have rolled borders, which you could see in this example and in this example here on the right bottom. And they also have telangiectasias, or little broken blood vessels, which you can see in the center. On the bottom left, you could see an example of more of a superficial type of basal cell, and that's more common on the trunk and extremities, and sometimes it could be confused with eczema as well. This is an example of squamous cell carcinoma. You can see it looks quite different. It has more of a keratinizing center, which is kind of rough and white and crusty looking. And again, you can see it's most common in the sun exposed areas here. For example, on the bottom left is an ear, and in the middle is a hand. This is an example of what melanoma looks like, and we'll talk a little bit more about each of these different types. So before we go into more detail about the different types of skin cancers, I just wanted to talk very briefly about actinic keratoses, which we consider pre-cancers or precursors to squamous cells, as well as less often basal cell carcinomas. So these present as dry, scaly patches or spots, and they're precancerous growths because they can transform into squamous cell carcinomas albeit at a fairly low rate of about 1% a year. But because of how common they are, we see it pretty frequently. They're more common in fair-skinned individuals and develop after years of sun exposure in sun-exposed skin. Here's a patient of mine presented to me with 3 biopsy-proven squamous cell carcinomas at the 1, 2, and 3 marked areas here. But you could see he has extensive sun damage. He has discoloration of his scalp. He also has lots of roughness and keratotic growths and papules on his skin. And many of these are precancers. They're squamous, they're actinic keratosis, but some of them have already developed into squamous cell carcinoma. So for that reason, we like to treat these AKs, as we call them, to prevent that transition into a squamous cell carcinoma. So the treatments vary. There are focal treatments where we just treat the individual spot with destruction, such as with cryotherapy, which uses a spray of liquid nitrogen, which is very cold, to freeze the surface of the skin and eliminate the actinic keratoses. There are also topical therapies, which are creams, and they work in different ways. There's immune modulators, there's topical chemotherapy agents, as well as other creams. And then there are also in-office procedures that could treat the entire surface, and they include things such as photodynamic therapy, chemical peeled and laser resurfacing, which essentially remove the top layer of sun-damaged skin and allow your skin to rejuvenate itself by new skin cells coming in the areas of sun damage. Basal cell carcinomas are the most common skin cancer. They develop after years of frequent sun exposure and sometimes indoor tanning. So sometimes I'll see young females or males that have frequented tanning salons coming to see me in their late teens or early 20s. And that's usually a population where we don't really see skin cancers develop, but in those that either are very fair skinned and grew up in very sunny climates, such as California or Florida or Arizona, or those that have frequented tanning salons. Unfortunately, don't realize the repercussions of this and end up developing skin cancers much earlier in life. Most common on the head and neck, and sometimes the upper extremities or the arms. And early diagnosis and treatment is important to prevent both mainly morbidity. It's very rare to have mortality from basal cells, but because they present at sites that are often very visible, that are sun exposed, they could cause a lot of morbidity if they grow large and therefore require extensive surgical removal. Squamous cells are the second most common type of skin cancers. They're more common in fair-skinned individuals in areas of sun exposure. They can cause local skin destruction as well as disfigurement locally, but they could also metastasize or spread to other areas. And again, very important to diagnose them and treat them early. Treatment options for the non-melanoma skin cancers, which include basal and squamous cell carcinoma, are multifold. So for the ones that are very superficial, we could sometimes treat them by electrodesiccation and curettage, where we basically scrape the surface of it and then burn with an electric needle the base of it. It's very simple and rapid and inexpensive, but with that treatment, we don't check the margins histologically to make sure under the microscope that we've cleared everything. So it does have a higher risk of potentially coming back and therefore needs to be watched closely. Surgical excision uses a defined margin of normal skin, and then we basically remove the skin in an ellipse and then close it usually in a straight line. So basically we remove this fusiform or elliptical shape and then bring this edge to meet this edge in a straight line. And with that, you have a better cosmetic result typically, and also less chance for it to recur because we're actually checking the margin so we could know after about a week or so of tissue processing time whether or not we've gotten everything out. We do have to sacrifice a little bit more of the normal skin, as you can see here around this growth, because we need that margin of normal skin to ensure that we've gotten everything. And then the other treatment modality, and this is what I do in my practice, is called Mohs surgery. And this is a very busy slide, but I'll walk you through it. So basically here, imagine that this patient had a skin cancer, a basal cell carcinoma, if you will, on the side of the nose, the nasal side wall. So we essentially cut it out, and then we take that tissue, and immediately by using a rapid form of histology called frozen sections, we're able to then examine that tissue under the microscope to know whether or not we've gotten everything out. And so because of that rapid tissue processing, and because the same physician by definition serves as both the surgeon and the pathologist, we're able to take very narrow margins. And so this is very important in areas that are important for either cosmetic reasons or functional reasons, such as the head and neck and some other areas of the body. And if we need to go back for more because there's still malignant cells left over in any of the areas, the patient is still in the office because this is all done in real time. We could map out precisely where the tumor still extends, such as in this example, piece 2 and 3 still have residual basal cells. So we go back to that area and we take a little bit more and then look at it again under the microscope until we get to the point that everything is all clear. So it's one-stop shopping after the tumor is removed. Usually the Mohs surgeon will then go on to do the local reconstruction to stitch up the skin so that the patient leaves with, having the tumor removed, examined to make sure that it's adequately removed with the appropriate margin, and stitched up. It's also very safe because it's all done under local anesthesia. So then melanoma is the least frequent but often the deadliest type of skin cancer if it's detected late. So 1 American dies from melanoma every hour. So by the end of our presentation, somebody would have died of melanoma. They can develop in old moles or de novo, meaning in an area where there was no mole before. And early diagnosis and treatment is really crucial because for early stage melanoma, the prognosis is excellent. Whereas for late stage, we do have more treatment options available to us now compared to maybe 5-10 years ago, but it still has a significant decrease in the patient's overall prognosis and a high mortality. And we'll talk about the ABCDE warning signs of melanoma that can help with early detection. So here they are. So A stands for asymmetry. So basically you want to see if you divide the mole or the lesion in question down the middle, does one side look like the other? Are they mirror images? And as you can see here in the normal mole, it would, whereas in the melanoma, it doesn't quite match up. So it's asymmetric. B is for border. So when the borders are ragged or irregular, so you could compare this mole here, which has quite even borders, to this melanoma, which has kind of jagged, irregular borders, and they're kind of hazy and fuzzy. It's hard to see where the melanoma ends and where the normal skin begins. C is for color, and normal moles or growths should have an even, uniform color, whereas in melanoma, there's usually a variation of different shades of brown or black or sometimes red and blue. And you could see that example here. And D is for diameter. So if it's larger than 6 millimeters, which is about the size of a pencil eraser, then that is potentially a concerning sign. And I'll also add E, which stands for evolving. So if something is changing, that could be a worrisome sign and should be presented to a dermatologist. So these are all examples of melanoma, and you could see they all have the ABCDs. We can't obviously assess the E in a photo, but you could see they have asymmetry, irregular borders, a variation in color, and it's hard to tell the size of it, but they're probably larger than a pencil eraser. So early melanoma is curative. I treat early melanoma almost daily in my practice, and knock on wood, my patients have an excellent survival. However, when melanoma becomes thicker, then we need to do additional studies, surgery, and systemic therapy. So surgery is curative for the thin melanomas, but might not be enough for the thicker melanomas, which might require adjuvant treatment in addition to surgery. I'll also just spend 1 minute talking about benign growths, such as seborrheic keratosis. These are very, very common. They're waxy or warty-like. Sometimes they're referred to as barnacles of age, and they could be few, or some patients have hundreds of them. They could vary in color from skin tone to brown or even black. And sometimes, although they are completely harmless, they can worry people, because when they see them and then they also see examples of melanoma, sometimes it's a little hard. So here are all examples of seborrheic keratoses. These are very, very common causes for patients to present to the dermatologist office with concerns. And although sometimes they don't look so nice, they're not worrisome at all, and they're very common. So I'll just talk in the last few minutes of the talk about how we can prevent skin cancer and what we can do to help us to safeguard our skin from the sun. And then we'll have about 10 to 15 minutes for questions, and hopefully that'll be enough. So seek shade whenever it's appropriate. The sun's rays are strongest between 10 and 2 p.m. So if your shadow is shorter than you, seek shade. I am a big fan of protective clothing. I'll show you a photograph that's already a couple of years old of how me and my family go to the beach. And I like protective clothing because it works better than sunscreen, and it's more reliable. It also doesn't require reapplication, and it's less messy. Generously apply sunscreen when you are going to use sunscreen, or into areas where obviously you can't use protective clothing. And make sure that you reapply frequently, about every 2 hours or so. And even more frequently if you are swimming or towel drying or sweating excessively. Use caution near water, snow, and sand, because oftentimes you also have reflection off of the water or off of the snow or sand, so people don't realize that they could really get a sunburn in the snow, especially if you're skiing and you're up on the mountain and there's lots of snow and sun. Avoid tanning beds. So there's a misconception that they're less harmful than natural sun, and that's really not true. And make sure that you perform regular self-skin exams and you look for any changes to your skin. I recommend doing this about once a month after the shower. Look yourself over, and then for the back, you might need either somebody's help, or using 2 mirrors could be helpful. And generally, I recommend seeing a board-certified dermatologist to do what we call a total body skin exam, where we basically look you over head to toe on a regular basis. And that could be done annually, once a year, or that could be done more frequently if you've had skin cancer, or if you have a strong family history, or lots of atypical moles. We also do free skin cancer screenings at Weill Cornell once a year. Usually it's done in May. Unfortunately, due to COVID, this year we are unable to do it, but that's another way to do it if you're unable to do it with your regular dermatologist. So with that, I will skip to the slide as promised of my beach, or in this case, lake vacation. And you could see we're all covered up. We took our hats off to take this picture. But generally speaking, this is my 4 kids, and they're covered from head to toe in essentially armor when we go out, and I try to do the same. So I thank you for your attention. Actually, I'll put this slide up as well. I think this is a funny cartoon where the pig says to the bacon, next time you'll try a little sunscreen. So with that, I will stop sharing, and I'm happy to take any questions.
Thank you very much, Dr. Minkis. I like that, how you end on that cartoony note. And also, thank you for sharing the photo of your family. That's very nice and very personal of you. I tend to wear a lot of clothes when I go to the beach too, personally. So I'm glad I'm doing the right thing, and it's not just me. A couple questions that came through today, and then I got actually earlier. So I've been kind of trying to categorize these. There's been a few questions about SPF specifically. And if you can maybe talk a little bit about perhaps the difference between SPF 30 versus 50. There were actually a few questions about those specific
Sure.
strengths themselves.
Yes. So absolutely. I have some slides on sunscreen. There's one here that I think actually would be helpful for this. So let me share my screen again. Okay. So could you see could you see the screen? Could you see my slide?
Yes.
Okay, perfect. So as you can see, there's photons of energy that the sun emits. And so as you can see, with no sunscreen at all, if the sun emits, hypothetically speaking, 100 photons, all 100 of them will enter the skin. With an SPF 15 sunscreen, you have 93% protection, so 7 photons could still enter the skin. Whereas with SPF 30, you have 97% protection, and only 3 photons will enter the skin. So generally speaking, we recommend wearing SPF 30 or greater. Once you get to 30 versus the difference between 30 and SPF 100, for example, is far less than the difference between SPF 15 and 30 or 8 and 30, etc. But that comes with a little bit of a caveat, and that is wearing the appropriate quantity of sunscreen is important. So here is actually for, if you could see the slide here, quantity really counts. So in order to get the SPF that's written on the label, you actually have to use the appropriate amount of sunscreen, because otherwise you're not really getting the SPF that they're marketing. So in order to get, let's say SPF 30, if you're going to be going outside and you're wearing, a swimsuit and you want to cover your whole body, you really need to use 1 ounce of sunscreen for the entire body. So a full shot glass of sunscreen. Most people, when they apply sunscreen, they use 2 dabs and then they start spreading it. And with that, they're really not getting the SPF that's marketed. So there, if you're using a much higher SPF, but a smaller quantity of it, you're probably still getting a higher SPF and greater protection that you would with a SPF 30. Does that make sense?
Yes, yeah, I believe so. And whoever asked that question, just feel free to chat if you have any follow-ups. All right, so I think we'll stick with maybe the second part of your talk, because there's a few questions that came in, again, pertaining to sunscreen and SPF, and then we'll get to a couple questions from the first part.
Sure.
But, a couple folks have asked specifically about the ingredients to look for, perhaps the best ingredients to look for in sunscreen products, and what to avoid.
Perfect. So again, I think I have, since there's a bunch of questions on this, let me go back to my talk again. Okay, here we go. So broad spectrum is something that I often recommend to my patients, especially when they ask what sunscreen should I use. So that's the number one thing that I would recommend, is using one that's broad spectrum, and SPF 30 we already discussed, or greater. So broad spectrum essentially means that it protects against both UVA rays as well as UVB rays. And both of those, the UVB rays contribute more to skin cancer development, whereas UVA is more in aging, but both of them can prevent sunburn, and used together, they're most effective. So SPF, we already discussed, I'm gonna skip that. There's also, sometimes you'll see labeling for waterproof sunscreen. There really isn't such a thing, but the ones that are marketed as such, stay on the skin a little bit longer, so they're more water resistant. So the FDA meaning is how long it could stay on wet skin, so whether it's 40 or 80 minutes. So water resistance is effective for 40 minutes in water, whereas very water resistant is effective for 80 minutes in water. Regardless, we recommend reapplying every 2 hours if you're not in water, but if you are in water, depending on which type of sunscreen you're using and what it says on the actual container, that is how frequently we recommend reapplying it. And as you can see, it's a little hard to do. Most people are reluctant to reapply sunscreen every 40 to 80 minutes, or every 2 hours even can be burdensome. And that's why some protective clothing could often be easier to do. Now, as far as the ingredients go, there are 2 major types of sunscreens in terms of the active ingredients. There are what we call the physical sunscreens, and the chemical sunscreen. So the mineral sunscreens or physical sunscreens, they actually reflect the UV radiation away from the skin. So they sit on the surface and they kind of reflect the UV rays. And the active ingredients that you should look for the physical sunscreens are zinc oxide or titanium dioxide. They're also the ones that are marketed for babies or for sensitive skin because they're safe for children 6 months and above. And the chemical sunscreens, there's a lot of press and negative press about them. Generally speaking, they're still very safe. And although there have been some studies that show that there's some systemic absorption and that, in very, very high doses, like 400 times the cumulative amount that any human will actually use in their own personal applications, it could be potentially carcinogenic in laboratory animals. I still sometimes use them, and they're a little bit trickier in that sometimes they could be broken down by heat or by sun, and they also have to be applied at least 15 minutes prior to, because what they do is they absorb the UV radiation before it penetrates the skin. And so they don't start working immediately as soon as you put them on. So if you put them on once you go outside, you have about 15 minutes that you're not protected from the sun. So it's a personal choice as far as whether to use the physical blockers or chemical blockers. I think the physical sunscreens with the zinc oxide or titanium dioxide work a little bit better, and they're a little bit more reliable. The downside is they do leave a white residue. So if you think about photos of surfers from the 80s that had the, white nose, that's essentially, what you will look like. They have reformulated some of them to make the zinc particles smaller and therefore leave less of a white residue on the skin. But generally speaking, they will still leave a little bit of a white film. There are newer products out there that are tinted. So if you have a little bit of a darker complexion, or you don't want that white look, you could get the ones that are tinted, and those will leave more of like a brown tint on the skin. And some people like that, and they use that almost like their foundation or concealer. But those are the main differences between the physical sunscreens and the chemical sunscreens. Hopefully that answers.
Yeah, thank you. It sounded very detailed from my perspective, for sure. I do want to we have a few minutes left before 7 o'clock, so I do want to give an opportunity for these folks that asked about the first half of your talk. There are some more SPF. I feel like we could talk about SPF and protective clothing till the cows come home, right? So I just want to turn it over to maybe the first part and give these other folks an opportunity. So 2 questions came in. I think I'll start with this one on shingles, the vaccine specifically. This individual is wondering, they had the shingles vaccine 6 years ago. Do they need another? Keeping in mind that there are new and different vaccines out now.
I advise them to speak to their primary care doctor because they would be best suited to answer that question. They would know which vaccine that they got, how many doses of it they got, and if they need a booster of it.
Great. And the last one here I see for the first part of the talk was, do you recommend oatmeal baths?
Very rarely. Sometimes we recommend it in children that have, pretty severe eczema. But usually for just dry skin, we recommend actually taking quick lukewarm water showers and then just applying a good thick emollient cream afterwards. And sometimes an oatmeal bath could be soothing if your skin is very irritated, or like I said, if a child that has severe atopic dermatitis, sometimes you do that, or bleach baths, but generally speaking, that's not a common recommendation that we make.
Got it. Thank you. Okay, those were it for the first half. So let's get back to these SPFs. We have a couple of minutes left. Actually, this one's more so about, I believe, ultraviolet protection clothing. So do you need to wear, is it better to wear that type of clothing, or is regular clothes, kind of fabric, okay?
That's a great question. So it depends on what the fabric is actually made of. So a white cotton t-shirt, for example, especially if it gets wet, like if you're using it as a rash guard, is only minimally protective, because a lot of the sun could actually penetrate through it. And you could, I'm sure we could all imagine, when somebody has like a white t-shirt and it gets wet, you could kind of see through it. So that material really isn't sufficient. The heavier fabrics and the darker colored fabrics, like denim, for example, is an excellent sun protection clothing, but it's also very hot and impractical for certain activities or for certain weather. So the clothing that's actually marketed as sun protective clothing, they've been actually tested, and they filter out 99% of the UV rays, and they're also made out of fabrics that are very light and will not you won't overheat in. And there's many different companies that produce them now, and some produce clothing that's more appropriate for more kind of like active wear in the sun, like yoga pants or golf shirts and things like that. And then there's other fabrics that are more appropriate for swimming, that dry quickly, for example. And again, all of these are really have been tested in various conditions to filter out 99% of the UV rays. So hopefully that answered that question.
Yeah. The last one here that came through the chat is about, I guess, receiving vitamin D. So do you actually, does your body absorb vitamin D when you wear sunscreen?
Yeah, so I think that vitamin D is it's an important topic. I'm not sure if I have, I had no, I think I took out the slide on vitamin D. So it's a little controversial because there is a big push among the UV tanning, the indoor tanning industry, to say that tanning is actually important because of vitamin D. And there's been lots of studies on this, and they've even tested surfers in Hawaii to look to see whether they have the appropriate vitamin D levels, because they're outdoors all day long in the water and in the sun. And they were even not at the appropriate levels. So my recommendation with vitamin D is really to try to get it through supplementation and through diet. That is the best source of vitamin D. And in order for somebody with fair skin to get the amount of vitamin D that they actually need from sunlight, they're going to cause a lot of damage to their skin. So you're much better off actually supplementing it and having a diet that's rich in vitamin D, as well as taking nutritional supplements if necessary of vitamin D, than you are trying to obtain it from the sun. Also, living in New York, which I'm assuming most people on this call are, you're unlikely to get appropriate levels of vitamin D year-round from the sun anyway, even if you were to try.
Yeah, understood. Yeah, that's really good to know. The last one I see here, hopefully it'll be a quick one. I know we're a minute or two over. Can I assume if I don't get burned through my clothing that it protects me? An example, a long sleeve athletic shirt on a bike ride.
Yeah. I mean, if you don't see tan lines, then you're fine. And actually, a lot of athletic clothing now. I was at an athletic store the other day looking at bike shirts, and I noticed that most of them actually had UPF, which is the equivalent of SPF, but for clothing markers. So I think a lot of the lighter athletic clothing now, they're taking this into account, and they're trying to help patients to also, or not patients, help people, help the public protect their skin from the sun, in addition to being made specific to that sport that the person is practicing. So yes, right. if you're not seeing a tan, then you're fine. But if you see that it's not only burns, but it's also tanning of the skin, that is a sign of damaging of the skin. So it's not only burning, but if you see your skin is tan, then that's a problem. Otherwise, you're fine.
Right. Yeah, that definitely makes sense as well. Well, those were the questions that came through chat, also the questions I had ahead of the session, and we're a little over, and thank you so much for your time, and thank you for being with us. It's always nice to have you for our seminar series, and I know last year you did this in person and this is virtual. We're all kind of acclimating. But yes, so I will thank you one last time. I'll also thank the attendees, And a reminder, you're going to get an email, most likely tomorrow, with a link of a recording of this for all of you to enjoy and kind of share far and wide with your family and friends.
Thank you very much,
All right.
Antonio.
Thank you. Have a good evening. Goodbye, everybody. Take care.